You're listening to All the Pieces, a podcast created to keep you informed. Now here's your host, Chief Quality Officer, Dr. Curran Mohan.
Hello and welcome to another podcast of All the Pieces. I'm your host, Dr. Mohan. Today we're talking about something that is endemic to our society, obesity, and its variant, morbid obesity. As we all know, this is something that is part of our culture for many, many decades now. And a lot of things have led up to that endemic or epidemic, if you will. But there are also solutions out there. One such solution is gastric bypass surgery, as is commonly known, or bariatric surgery. Changes are made to the digestive system to help individuals lose weight when diet and exercise haven't worked, or when there's a serious health problem affected to them by their weight gain. Talking about that subject today, I have my lovely guests today, Dr. Rafael Alvarez and Nicole O'Hare, a nurse practitioner, both from the Mosaic Life Care Bariatric Center of Surgery, really, here at St. Joseph. So, welcome.
Thank you. Very excited to be here.
Thanks for having us.
Absolutely. So, I asked this question to all my guests before we get started to our topic, which is, do you listen to any podcasts?
Yeah, so I was very ashamed to learn that we had one ourselves here at Mosaic, and I promise from now on I'll be a listener. But I do have some experience listening to podcasts, and the one that comes to mind, so I train at the University of Michigan, and I'm a Wolverines fan. I don't know if you know, but they recently won the national championship.
Yes, they did.
And that there's a couple really good kind of analysts out there that run podcasts, and they do it on YouTube for the most part, so that's kind of mostly what I listen to.
Excellent.
On my 45-minute ride to St. Joe's in the morning.
Oh, the downtime is essential to decompression, isn't it?
Absolutely.
What about you, Nikki?
I don't listen to many, just some murder mystery type podcasts and
Excellent.
that kind of thing.
You know, it's wonderful. I feel there's a lot of people doing podcasting, me, and not a lot of people doing pod listening, you know, so, but here we are. Our viewership has gained 2 more followers today, so thank you and welcome again. So as I talked about earlier, bariatric surgery is obviously one aspect for weight loss. Can you tell me what the ideal patient for bariatric surgery is, Dr. Alvarez?
Yeah. So, you know, first to talk about that, I think I look at it from a patient's perspective, and always a patient that's a good candidate for bariatric surgery is a patient that wants to have bariatric surgery. And it usually takes a lot of thought for somebody to come to our clinic and really sit down and talk about bariatric surgery. As you can imagine, these patients have usually tried and most of the time not really be able to be successful with dieting and exercise. Sometimes many of us, see patients that have tried, obesity, anti-obesity medications as well, right. and then that's when they come to our clinic, and again, it's a process that takes sometimes years for patients to realize that, obesity, it's a disease. Now I have these high blood pressure and high cholesterol and diabetes, and there's nothing really I can do on my own with the tools I've been given to really address that problem. So then they come to our clinic. So I think the first criterion would be a patient that's that understands that that is a treatment opportunity and really an opportunity to improve their health and quality of life. So once you have that, I think, and along those lines, then you have to look at what are the clinical criteria that allows a patient to really benefit from bariatric surgery. And we look at something called the body mass index or BMI, and what that basically is a standardization of weight by height. So basically take both numbers into account, and it gives you a value. And usually, largely, most for those patients that have coverage, plans usually follow Medicare standards, and that usually means a BMI of 35 with at least one obesity-related problem. And again, this would be things like diabetes and high blood pressure and high cholesterol. And then the other bigger category, or big category, would be patients with a BMI of 40 or higher, even if they don't have an obesity-related problem. So again, BMI of 35 to 39.9 with an obesity-related problem, or a BMI of 40 or higher, even in the absence of any obesity-related problem.
Gotcha. So 40 and above automatically qualifies them.
Correct.
But if you're under 40 or above 35 and you have, say, diabetes or something related, you will be a candidate for bariatric surgery.
Exactly. And I would say the one exception would be Medicare. And Medicare, even with a BMI of 40 in their eligibility criteria, patients do need to have an obesity-related problem.
I understand. So, and for our listeners out there, BMI, as Dr. Alvarez has mentioned, is related to your height. So you could be 200 pounds and 6'5" and have a normal BMI, or you could be 4 feet and be 200 pounds and you can have a high BMI. So
Exactly
it'll relate to your height. It's just not it's a dynamic number. And excellent. Is there any existential threat to bariatric surgery with the new advents of, say, Ozempic or Wegovy, which just kind of seems to be in vogue in our normal sort of culture now?
Yeah. So, for the past decade or so, we've been seeing, a lot of the pharmaceutical companies really focus on developing tools to treat obesity. And it's not a surprise because, for the past 50, 60 years, we've been really working as a, society in terms of, obesity has become an epidemic. And right now, I think, it estimated that by 2030, 50% of the adult population in the United States will suffer from obesity. Right now, I think we are kind of on the 43 to 47%.
Only 40.
Only 40, exactly. So then, a pharmaceutical company has taken notice of that, and the opportunity and the need really for tools that then, allow patients to be successful are counteracting obesity. So like you mentioned, we have a whole gamut of drugs right now, basically falling into what we call the GLP-1 agonist category, and GLP-1 stands for glucagon-like peptide, which is a receptor we all carry in our bodies, and it's basically, it's present in many parts of our body, even the brain, the gut. So many different actions of these medications. These are usually shots, not unlike insulin that patients give themselves once a day or once a week. There are also pill formulations for these medications. And I think, if anything, from my perspective, it gives us, providers really interested in helping patients that are struggling with obesity, additional tools to really help them through. Now, it's very interesting you mentioned that as the possibility of an existential crisis. And the truth is that even with surgery, even with medications now, a very small proportions of patients that would otherwise benefit from these therapies actually can take advantage of. So there's a lot of problems with access when it comes to obesity therapies, both surgeries and medications. So even though we have all these very effective treatments, unfortunately, just a minority of our patient population can benefit from that.
Excellent.
So to answer your question, I guess in a short manner, no, I don't think it's putting bariatric surgery kind of out of business. I think there's, unfortunately, there's a lot of obesity in our society, and I think the more tools we have, the better.
And at the end of the day, our goal is to help the patient. If it's coming through GLP-1 agonists, as you mentioned, or surgery, or what they call the traditional way, which is weight loss, diet and exercise, the end goal is to reduce that weight so it can prevent future. Just before we go to the access of care, I want to just define what is bariatric surgery. So, Nikki, I know bariatric surgery is sort of a term, but what different types of bariatric surgery are available?
So there's the Roux-en-Y gastric bypass and the sleeve gastrectomy are the two that Dr. Alvarez performs.
Okay. What's the difference between the two? I have no idea about what that procedure looks like.
So with the gastric bypass, he makes a 5-centimeter pouch out of the existing stomach and then brings up the jejunum part of the small intestine and then makes a Y formation. So it's a restrictive and malabsorptive procedure, where the natural gastric juices also go down the line, so you still have those. So you can lose about 70% of excess body weight with that procedure.
Oh, wow.
The sleeve gastrectomy, he cuts away about 80% of the stomach. All the plumbing per se is left intact, but he cuts that away and leaves a banana shape to the stomach. And so patients can lose about 65% of excess body weight with that procedure.
That is amazing. And obviously, these surgeries are just that, surgeries, which is something we have to be cognizant of. What is the usual turnaround time or the weight loss time? So from surgery to the 65 or 70% reduction in their excess body fat, how long does that take usually? Is it overnight? I'm guessing not, but
It's about a year.
about a year. That is excellent. So new wardrobe in a year. And how many of the patients keep it off? Because that's the big question, is it? If I'm going under the knife, is the juice worth the squeeze? So roughly how many of the patients would you say, keep the...
Most of them do. There's, all these lifestyle modifications that are necessary to keep it off. And so we really work really well with our patients and talk to them extensively before and after surgery to keep them on track with their weight loss goals. And if they're slipping, we, counsel them and, try to get them back on track. We can use medications to help with that. But our goal is to keep them on track and keep them.
Right. Managing expectations is a big part of bariatric surgery. And sometimes there is a misnomer in the community or a general public at large that if I get the surgery done, my job is done. That means the weight's going to come off, which it will, but the patient still needs to go and still make those lifestyle modifications. So if I have, say, a BMI of 45 and I come into your bariatric surgery center and say, I want to drop the weight, from that intention to the surgery, what steps are taken by your team to make sure that the expectations are managed well? I'll direct the question.
Yeah. So I think you touched on a very important topic in healthcare, which is managing expectations. Right. There's a lot of new therapies, medical therapies and surgical therapies that we have. And it's, I think, up to us, the providers with the most knowledge, to make sure that when that patient comes in, seeking help, that we're able to deliver a factual, clear, picture for them. So that way there's a match between what we're able to offer and what they will get over time. So one tool that I really, really like and that I use all the time in my clinic, as we are a center of excellence, as used to be known, and now it's a nationally accredited center. We have access to national level data that is actually pretty accurate, and it's a lot of fun for me to use, and you get to input or all of the patient characteristics, so like sex and ethnicity and weight. And obesity-related problems, and all the things such as smoking status and things like that can make a difference for outcomes, and you get a good picture, like at 1 year, of what the effectiveness of surgery might be in that patient population. And again, these numbers are based on national level data, looking at thousands of patients that get surgery in high quality level centers, across the country. So, probably I like to think that, the highest quality surgical care in the world. And then you get to sit down with the patient with those numbers and really go to like, well, this is what your weight loss is going to be like. This is how much your BMI will drop, depending on which operation, the patient will be having. And then you can also talk about, I use, that tool to also talk about complications. So like, these are the risks, these are the complications that can happen, and these are the national level risks. And then I go a step beyond where I tell them like, and this is how my personal risks compare to the national average. Because I think if you're having surgery with me, you should know that in order to make an informed decision. So I think it's a really nice tool that I've encountered that allows me to really, kind of like get down to the expectation at probably the highest level we can, when it comes to setting expectations. Now, the other part is, how long it takes for a patient once they come into the clinic to have surgery. And I would say that the big limiting factor right there is going to be what kind of coverage they have and what are the additional requirements that insurance has to be able to allow the patient to have bariatric surgery. And specifically, the one that I see can delay patients the most is a medically managed weight loss requirements. And it's highly variable across plans, and it can be from no requirement to up to 6 months usually. So if a patient has that, then they need usually monthly visits with a provider that's going to do intensive medically managed therapy, and usually it cannot be with me, the surgeon, so it could be with Nikki right here. Sometimes they have their specific providers that they kind of like send patients to. So this would be kind of like the thing that for the most part can delay surgery the most. For the most part, I think we have a really good system here at Mosaic. We have a really good infrastructure, a very experienced team. So most patients can get to surgery, absent that requirement, within 2 months usually.
Oh, wow. So depending on the coverage, it can take up to 6 months to make sure that the patient has taken all necessary steps to reduce their weight. And despite that, if there's no reduction, then surgery is still viable if they meet the criteria of the BMI with the comorbid condition.
Absolutely.
I think I understand now. So, you kind of touched on complications, and I think you mentioned Roux-en-Y, Nikki, as well as the gastric sleeve. What are the common complications a patient might encounter? We're going to keep Dr. Alvarez out of it because he might say there is no complications, correct?
Zero complications.
Zero
We don't have
complications.
any.
But Nikki, what have you encountered in your practice?
So the biggest or scariest complications that we could encounter would be a leak from the anastomosis.
What is an anastomosis?
The junctions that are made.
Where the plumbing is connected?
Yeah, where the plumbing is connected, which does not happen very often at all. But that is, one of the worst complications that can happen. That or an internal hernia can happen.
Right. Then those are the ones you talk about to the patients that, and obviously the other stuff you can certainly have infections and death and all the standard stuff. Okay, and have you encountered? I hear from people sometimes like I had bariatric surgery, now I have to take all these vitamins along with it. Is that something that's part of a bariatric surgery sort of journey?
Yeah, so depending on the bariatric operation, there are expected nutritional deficiencies, and it has to do where how our body works normally or how our physiology, just a term for processes in our body that keeps us healthy. So it has to do where most of these nutrients get absorbed. Let's say the Roux-en-Y gastric bypass, like Nikki mentioned, a small pouch, stomach pouch is created, and then there's a rearrangement of the small intestine, effectively bypassing most of the stomach and the first portion of the small intestine. So, in this case, nutritional deficiencies such as B12, can happen. B1 or thiamine is another one that we see frequently. And then the other ones that we most commonly see are calcium, vitamin D, and iron. So those would be largely the most common nutritional deficiencies after bariatric surgery. So because of that, we do have strong protocols in place that encourage and I should say require patients to go through vitamin supplementation really for the rest of their lives. This regimen is very aggressive in terms of vitamin supplementation during the first 6 months, and there's a reason for that. This is when most of the weight loss happen. This is when dietary intake is most restricted, and this is still where your body is trying to adapt to the new physiology, to all the changes, the anatomic changes that therefore will give you a new physiology, if you will. So then during this time, patients are required to take a multivitamin. They take that twice a day. A B complex supplement, they take that twice a day. vitamin D and calcium, they take that twice a day, and then an iron supplement, and again, they take that twice a day. Eventually, even with a room-wide gastric bypass, which tends to be one of the operations that can result in the more commonly in vitamin deficiencies, you can potentially get patients to minimal vitamin supplementation. And I'd say minimal, still usually optimally, we're talking about 3 pills a day or so. And then again, this would be calcium, vitamin D, multivitamin, and iron.
So it's not a huge onerous, after the first 6 months that the patients are just taking pills and pills. They'll take a normal variety of multivitamin with some extra supplementation.
Yeah, and there are, I think we try to go with our main protocol, but there are, some patients cannot tolerate this or that, and there are, different ways to, go about that. There's like liquids and like chewables and even patches, vitamin patches, and as long as we're constantly measuring their vitamin levels and such, we can always detect effectiveness, and we can always adjust whatever vitamin supplementation regimen the patient might be on.
Well, that's good to know that the patients have a post-operative follow-up on a routine basis, so they're not missing on very essential micronutrients. What is a normal recovery time for someone who has a Roux-en-Y or a gastric sleeve surgery?
Yeah, so recovery time is pretty similar, I would say, regardless of operation. One of the things that it takes about 10% of our practice, I would say, it's about complex, revisional bariatric surgery. We do that. Nowadays, we're doing it more and more as we have been able to establish, our practice now. I've been with Mosaic for over a year now. So
excellent.
Even in the complicated or complex revisional bariatric surgery, patients recover quite well. And the reason for this, as you would imagine, is the minimally invasive nature of these operations. So these things are done, these operations are done through small incisions. In the case of a sleeve, depending on patient's BMI, it can be as few as 3 incisions. And then for more complicated, revisions and reconstructions, and we might be talking about, 5 incisions plus minus liver retractor incision, but they're all very small. So then patients, pain is better, their infection risk is significantly reduced, and they get to go home and get back to their life a lot sooner than, let's say, 40, 50 years ago when these operations were being done through an open incision.
Right.
So then,
a giant scar going down your belly.
Exactly. So nowadays, I would say what I tell patients in the clinic is you come in, you have your surgery. Depending on the operation, it can take anywhere from an hour to 3 hours if it's a complex revisional operation. And then you're going to spend a night in the hospital. Largely, I think over 95% of our patients discharge home on their first night. Usually the ones that stay, one more night and such is because they're still kind of like getting used to their new anatomy, and they need a little bit more time to be able to drink. Dehydration, as we know, it's a big problem. I wouldn't say it's a big problem, but it is the most common problem that we run into. Talking about complications after bariatric surgery, and we have strong protocols in place just to make sure that patients are not discharged before they can meet their fluid requirements at home, because that largely is the number one reason that brings patients back to care. So then, I tell the patients, you're going to spend one night in the hospital for the most part if everything goes well. And then usually by 2 weeks, you're about 50, 60% back. And usually by 2 months, you're very close to 100%. And then there's a gradual, from that, like 2 weeks, like 60, percent or so to like, the 100%. It happens a little gradually, but they get there. And a lot has to do, again, with the dietary restrictions that are necessary for, both safety from a safety perspective and also effectiveness after the bariatric operation. So as you change your diet so drastically, there are changes that are expected in, kind of like energy and all the things that go along with it that kind of like takes about a couple months for patients to get used to that.
So 2 months after surgery, patients are pretty near close to their baseline as their body adjusts to a relatively new change in the physiology. So thank you for that. I think I've learned a lot more from this discussion than I did from my favorite consultant, Google MD. So I want to first of all thank you both for being here. And for our listeners out there, bariatric surgery is a serious decision, like any decision in life when it comes to your health. and it shouldn't be taken lightly. But if you do feel like you're a good candidate for it, despite making some good efforts on reducing your weight, please talk to your primary care provider, who can refer to Dr. Alvarez as well as Nicole O'Hare, or other members of our bariatric team to help you get the process started. And when it comes to access to care, I think you mentioned coverage is a big factor, but that's something your primary care provider as well as your the team here at Bariatric Care at Mosaic St. Joseph can help you with as well. So first of all, and lastly, I want to thank you both for taking the time and discussing a very serious epidemic in our country and the solutions we have here at Mosaic. So thank you for that.
Thank you for having us.
Anytime. And for our listeners out there, thank you for tuning in to another episode of All the Pieces. I'm your host, Dr. Mohan. And as always, take care, brush your hair.